Good evening, class. Professor Streb coming to you with another voiceover of my recap and review for Unit 11. This is care of the patient with common mobility or musculoskeletal issues. This is a shorter unit for sure. It usually is in Unit 11 because we only have a couple of days to get all this information out, but it still will be on your exam, so I would be remiss for not covering things like arthritis, gout, osteoporosis, fractures, strains and sprains, herniated disc, things like that. So, kind of just moving right into it. Osteoarthritis and rheumatoid arthritis are often confused. Osteoarthritis is when you have that deterioration of the articular cartilage in your joints. So, it ends up being kind of like bone on bone, right? Osteoarthritis is a degenerative type joint disease. That's used to be what it was called. It's the most common type of arthritis, and it causes a lot of disabilities. Very characteristic is the joint pain and that loss of function in that, like I said, in your fingers and joints because you don't have that cartilage anymore. So we aren't going to fix it because that's not what we do, but what we do know is that we need to talk to our patients about what the causes of osteoarthritis are, or maybe not the causes per se, but some of the etiology, if you will, when we start thinking about what triggers it. So we know that osteoarthritis can develop for all kinds of reasons, associated definitely by age. The older we get, smoking, that does everything, and so does obesity. That kind of puts more pressure on the joints themselves. But repeated trauma, you played a lot of sports and you get injured a lot. That can cause that degenerative loss of cartilage in the joints. Weight-bearing joints, like I said, in your hips, your knees, your ankles, things like that. The more you weigh, the more pressure you put on it, the more likely you are to have some kind of issues with the osteoarthritis. It's a progressive disease. That degenerative loss of cartilage doesn't slow down, and it's definitely something that becomes problematic because it ends up affecting your ability to do your ADLs, to live, to walk. Your mobility is decreased. You're in a constant state of pain. Family history, if you have autoimmune disorders, like you have like psoriasis and things of that nature, that too, lupus, those things can cause you to be a little more at risk for osteoarthritis. So your job as a nurse in here is to understand what some of the precipitating events can be and ways to prevent the disease progression, or where you're going to focus your main thoughts here, because you're not going to treat it. There's nothing for you to treat per se. You're trying to talk about the signs and symptoms and what some of the causes might be so they can slow the progression down. Rheumatoid arthritis, a little bit different. It's chronic inflammation of the joints itself. The actual cause for either one of these, not really known. We think about it as an autoimmune disease. Again, certain environmental factors can kind of put you at risk for this, like infection with certain diseases like viruses and bacteria. Research shows that smokers have the biggest risk, like nearly double for those who don't smoke. So if you smoke, you should quit anyway for obvious reasons, but this is just another reason and another problem caused by that inflammatory process. And we know that smoking causes inflammation, and inflammation affects our body all over the place. So what are we going to do once again? Well, there's nothing we're going to do per se, especially as nurses here, but we need to think about manifestations. We need to think about the signs and symptoms of what rheumatoid arthritis really is. So early signs and symptoms can be very general: loss of energy, fatigue. Think about inflammatory response. That's what we're talking about here. That muscle and joint stiffness, usually in the morning when you first get up, or after periods of inactivity, laying on the couch, you get up and everything kind of hurts. That could be an early sign and symptom that you have rheumatoid arthritis. So we would need to kind of have the patients really look into seeing their provider early. Late signs, or when you start getting the inability to move your joints anymore. So you get deformed bones, you get your fingers can be all crooked. My fingers look crooked all the time. I've gone to the rheumatologist multiple times to see if I have rheumatoid arthritis, and I don't. Apparently, according to the 7 times I went, become a little hypochondriac. But it's not uncommon to see crooked fingers and ulnar deviations, like in your wrist. That is very telling late signs of somebody who has rheumatoid arthritis. So understanding this, understanding that they're going to have some changes in their joints, let you talk to your patient and try to increase mobility and get treatment a little bit earlier. Gout is an inflammatory issue as well. It's a form of arthritis. They say it's a buildup it's a buildup in your joints, right? Like uric acid starts to build up, starts to like crystallize in the joints. That's what gout is. Gout is very painful. Gout, a lot of time people think about it as being in their foot or their big toe. I remember just as a child hearing about people who had gout in their big toe. But it can also be in your ankles and your knees, really any of those joints there. But just understanding what causes, what kind of the cause would be the uric acid that starts to build up. And it causes that pain, tenderness, that warmth and swelling. The allopurinol helps decrease the uric levels, acid levels in the blood. So if we can start getting our patients on allopurinol sooner than later, that's really going to help treat the acute attacks and then maintain that lower uric level in our patients, uric acid levels. Osteoporosis is something that we used to associate with older women. That's not exactly the case, but it's something that's still out there as maybe a misnomer. So chronic disorder, it's a loss of bone strength. The bone can start to get a little bit more porous, if you will, which makes you more susceptible to having breaks and fractures. Most people don't know they have osteoporosis until it's later. So as nurses, once again, we're not going to fix this problem, but we are going to talk about the risk factors with our patients. We're going to talk about patients who smoke cigarettes, who use oral corticosteroids for long periods of time, women who have estrogen deficiencies. Those can also put you at risk for developing osteoporosis. More importantly than that is thinking about the management. And what we want to do is prevent bone loss. And that is something that we have to really talk about our patients with, especially for people who are in those child-bearing ages, like women. You are also at increased risk for osteoporosis as well. But we need to think about an adequate intake of calcium and vitamin D, like drinking fortified milks and cereals. Those are going to help give you what you need. Do regular weight-bearing exercise. We know that daily walking can be something that helps prevent the progression of osteoporosis. So we need to consume calcium and vitamin D. Get out in the sun, absorb the vitamin D on your daily walk. Stop smoking. Avoid alcohol and caffeinated beverages. We know that those too start to deteriorate our bones. It's funny, in my mind, everything that we do nowadays causes more problems. If you smoke and drink and eat like crap and don't exercise, those are all things that you have control over. So this is why it's important for us to talk about this with our patients, especially our older patients. We know that the disease is found in older patient populations more than anywhere else. The use of steroids can contribute to osteoporosis. So just make sure you're talking to these patients, helping them figure out how to prevent the progression of this disease and what they can do to really help. Make sure that they're drinking lots of water. Make sure that they're standing often. Medications that help treat this can also cause other issues, right? The bisphosphonates are what we use to treat this, but they need to be drinking with a full glass of water. You want to fast for about an hour and remain sitting up, right? Because it can cause esophageal mucus irritation and reflux. So these are good teaching points you need to talk to your patients about. Oh boy, osteomyelitis. This is a nasty, nasty thing. Osteomyelitis is when you get a severe infection in your bone, the tissue of the actual bone itself. It is hard to treat, very, very difficult. You get a bone infection, it puts you at risk for losing that bone. So long-term antibiotic use is going to be something that our patients have to be prepared for. They might get a PICC line for this. But why do we care? Because we're nurses, right? We care about everything. But the patients who are most likely to get this are the older adults who have infective pressure ulcers. If you have immobility, people who are like paralyzed and can't get out, get off of their coccyx, people who have infective pressure ulcers especially the deep stage ulcers, are at an increased risk for osteomyelitis. So we need to start talking about this with our patients. We need to talk about, watching out for ulcerations anywhere. Think about diabetic patients who have ulcers on their feet. A lot of folks who are diabetics get the amputations for that reason. They get osteomyelitis, and it's not a good thing. So make sure you talk about, thinking about the right footwear and what you need to do. Foot ulcers can really be problematic as well. Things you have to kind of be on the lookout for: tachycardia, fever. That's always a sign typically a sign of an infection. Constant bone pain that is associated with movement. Oops, I was going somewhere. What else? Erythema, that edema, that warmth. A lot of times they're going to look at your erythrocyte sedimentation rate and kind of see what's going on there. Make sure you just talk to your patient about the clinical manifestations. So if they see this swelling, this warmth in their lower extremities, they can go to the doctor and get that prompt treatment. You need IV antibiotics as soon as you find this issue, and then you make sure your patient's aware that they could be on this treatment for 3, 6, 9 months. It just depends on how bad it is. And who's at risk? Once again, people who are sitting around doing nothing and get pressure ulcers. You got to think about that as a nurse. Fractures, we're all familiar with fractures. When you have a fracture, there's a few things we worry about. It's a break in the bone itself. It could be a simple fracture, it could be a convoluted, it could be an open. It just kind of depends on what you got going on here. We really have to pay attention to people who have breaks, people who have cancer, people who have osteoporosis. They have increased risk for fractures. So those patients, we need to be very aware that they have no falls and things of that nature. What can we do about fractures? Well, prevention would be good, but typically we don't see anybody until they come in after a traumatic event, and that's kind of what we look at. So what we're going to end up with is people who have fractures. If they have an open reduction, if they have some kind of surgical intervention, we are going to be watching our patients who have these internal fixation devices, right? Screws, plates, pins, whatever they have going on. And we just have to pay attention. We have to think about the skeletal traction. We have to observe what's going on. If a patient's on some kind of skeletal traction, they might have offsetting weights. We have to make sure those weights aren't touched or moved around, because if they are, it can cause that shortening of the muscle, and it can cause the bone not to heal correctly. So we always have to be cognizant of what's going on. We need to talk to our patients and their family to make sure they don't mess with anything. We need to monitor for a fat embolism. Anytime you break a large bone, let's say you get a femoral fracture, your likelihood of having a fat embolism is exponentially increased, especially on those big, hard bones, like I said, like the femur. How do you know somebody has a fat embolism? Well, you need to start looking for signs of an emboli, right? The tiredness, hypoxemia, the dyspnea, things that let you notice that there was a clot that kind of got dislodged, an emboli, and it probably went to your lungs. So those are things you really have to worry about with a patient who has fractures. Not the simple stuff, really, right? Like I said, just make sure you're monitoring your patient, make sure you're monitoring for pain, make sure you're looking at the distal extremity for coolness or pallor, diminished pulses, lack of sensation, that numbness. Any kind of circulatory compromise is where you are going to have to really pay attention. And then furthermore, look for a compartment syndrome. And a compartment syndrome is when you start getting too much pressure and it starts to build around and it tamponades. The pressure in the tissue gets so great that it causes the vessels in the leg or the extremity to be occluded. And that's what a compartment syndrome is. You might have to do a fasciotomy or an escharotomy or something of that nature, but we're not getting into that right now. Carpal tunnel syndrome, we've talked about this in the past. Carpal tunnel syndrome is something that affects the nerves in your wrist, basically. It goes along the forearm to the palm of the hand, and when it's pressed and it starts to squeeze, it becomes very irritated. So that burning, tingling sensation in the palms of your hands. We see this a lot with people who type and work in certain professions. So the non-surgical treatments are what we're going to worry about here. Splinting. Think about a patient wearing a splint at night. avoid daytime activities that provoke the symptoms, use NSAIDs to decrease inflammation, corticosteroids if they're prescribed, and do some kind of alternative things that help with mobility, like the yoga and the Tai Chi and stuff like that, that is less impact type of physical therapy, if you will, but it helps with mobility and flexibility. Strains and sprains, what's the difference? You know, a sprain is a stretching or a tearing of the ligament. A strain is a stretching or tearing of the muscle. So a sprain is your ligament, a strain is the muscle or the tendon itself. Does it really matter? Not so much to me, for being honest. What am I going to do for these people? I'm going to monitor them for the signs and symptoms of a problem: pain, swelling, bruising, the inability to move your joint. Same thing with the strain: muscle spasms, weakness, the swelling, cramping. Typically, we're just going to do that RICE. We're going to rest, ice, compress, and elevate. We're going to keep the patient off of that extremity and avoid use of those ligaments or muscles and tendons. And that's where you're going to focus. A herniated disc can occur anywhere in your back. It could be down in the lumbar section, your thoracic, or your cervical spine. Really anywhere. Back pain is a common reason for seeking medical care. We know this, nurses. Back pain is the most cited reason for nurses leaving the profession, right? Because back pain is debilitating and it hurts and it doesn't feel well. So the low back and the cervical vertebrae are the most typical places that you're going to have affected by these disc protrusions. The thoracic area is typically not involved. This is where you get a lot of the flexion, though. You sit a lot, so your L spine is usually curved. Your neck, you're looking down at your phone. So it's not uncommon to have those. So what are we going to do about this? Conservative management, it includes having the patient sit in certain ways for these lower back pain. Semi-Fowler's position with a pillow under your knees. It takes the pressure off. Make sure that when a patient has to have like a lumbar puncture, they might have to do a lumbar puncture to go in there and maybe give some kind of pain medication. So I'm trying to think what I was going to say, like an epidural. They might do something like that as well. So your patients might experience good pain relief by sitting in the chair, reclining in the chair. Take the pressure off of the lower back. That is going to help. So things that you really need to think about. But these patients who have herniated discs, they might need to go in and have surgery. They might need to have the disc removed, a discectomy. That happens all the time. Or a fusion. These are things we do with a herniated disc, right? So they can go in there and do the procedure, spinal fusion, whatever. Post-op cervical patients need to have a swallow test prior to taking oral intake. We need to make sure we pay attention to their level of consciousness. We need to look for sensation anywhere distal. If it's a C-spine type herniated disc, we need to think about anything that's affected below the area of trauma and look for sensation and things like that in the distal extremities, because they could very well have a loss of function. If we're not paying close attention, we might miss that. Lastly is the arthroplasty. This is a surgical procedure to restore the function of a joint, right? They resurface the joint, if you will. And an artificial joint can be used in like a knee replacement or a hip replacement. But this is a procedure that we often see when we think about people who have mobility issues, right? Surgery is not the first option, but sometimes it's performed when you can't get good pain relief anywhere else. I mean, literally, if the quality of life is so bad that they can't get anything going on, then they might go and do a total joint arthroplasty and go from there. Why do we care? Once again, you had surgery, and that can be problematic. So we have to worry about mobility and falling. We have to think about DVTs. Anytime you go in there and replace any part of the bone, you could cause a fat embolism. You could cause that lack of movement during surgery. You could cause that venous stasis, which could, complications could be bleeding, infection, blood clots, whatever. So it's going to be important for you to monitor your patient for any of these signs and symptoms post-operatively. Once again, you're not going to do anything to fix the problem. You're going to sit there and monitor and make sure you recognize early signs and symptoms of an issue and do your best to prevent life-altering outcomes or sentinel events.